Hi, everyone, and welcome to another edition of the 2024 Global PAD Impact Awards. Tonight, we are celebrating a true innovator in the field of peripheral artery disease diagnostics. The Pioneer in Diagnostics of the Year Award honors an individual who has made groundbreaking advancements in diagnostic techniques, transforming clinical practice and truly improving patient outcomes because of it. This year's recipient has developed a cutting-edge tool and methodology that has revolutionized the detection and management of the most advanced stage of peripheral artery disease, known as critical limb ischemia, or CLI. And her dedication to education and collaboration around this has empowered healthcare professionals and patients alike. So it is with great pleasure that we present this prestigious award to technologist Jill Somerset, a visionary leader in PAD diagnostics. Congratulations, Jill Somerset. Thank you so much for being here and for all you do for so many patients around the world.
Well, thank you very much, Kim, and everyone for this extraordinary award. It is such an honor to receive it, and I'm very, very grateful. Thank you.
So what inspired you to focus your career? I mean, this is an important question. What inspired you to focus your career on helping patients with peripheral artery disease?
It's a great question. I've been doing vascular ultrasound for 25 years, and in 2017, I decided to turn my attention to trying to decrease the rate of amputation. And I started up a limb salvage program at a small community hospital with another vascular surgeon, Dr. Des Tesso. And basically, we formed a multidisciplinary program in the community to try to decrease the rate of amputation. And that really launched my curiosity and passion around decreasing amputations, because the mortality and morbidity rate is so high. It definitely needed further attention in the community.
So can you describe, I mean, I'm sure that actually led to the technology that you're being honored for developing and educating the world about. Can you describe the technology that you developed for diagnosing PAD and how it differs from existing models?
Yes. So the current technology, or what we had back then, was more of an indirect assessment to diagnose peripheral arterial disease. Outside of direct duplex imaging, we had toe brachial index or ankle brachial index. And again, these are indirect measures. And to be honest, I get really frustrated by not being able to tell the vascular surgeons or other podiatry or wound care colleagues if there was enough blood flow to the foot using a non-invasive method. And that really led to curiosity and research. And really, I just scanned my own foot and realized that I could see the arteries in my own foot and thought, oh my gosh, this hasn't been done before. And that really propelled this really lovely journey of understanding foot perfusion. And at that time, there was a lot of journaling and looking at all kinds of metrics in the foot. We looked at flow velocity, waveform analysis, resistive index, acceleration time ratios, but acceleration time was the most sensitive. And therefore, that turned into pedal acceleration time, otherwise known as PAT. And this is a simple measurement of the onset of the systolic waveform to the peak to measure in milliseconds. And that time can now be applied to published criteria. So this is objective, accurate data that can be easily used with ultrasound that we have in many vascular laboratories today.
So for the patients, there was a lot of information in there that might be a little Greek to them. So we can start with just pedal, meaning your foot.
That's right. Yes.
Right. Okay.
So this is direct ultrasound of the arteries in the foot, on top of the foot and on the bottom of the foot. And where it's most important is we can use ultrasound to look at these arteries to the wound bed and determine if there is enough blood flow or not to heal a wound.
That's pretty amazing. It's amazing that no one had thought about this before you. Don't you always, I mean, you had to have been sitting there when you thought about this and going, someone has to have already done this, right? You had to have been doing tons of research and saying someone had to have done this. Where is someone else in the world that has done something with this? And then you might question your idea. Well, is it really that good of an idea if no one else has done it before? All those things go through your head, right?
Yes, yes, absolutely. And some people have said, "Oh, I look at the foot, I could see them," but I don't think there was any um, nobody put any objective data around it. So we spent many years publishing criteria and doing a lot of research, and that research continues. So almost 7 years later, we have over 20 publications of this technique that really have it's a global effort, which is really actually incredible because others around the globe have contributed to this great test.
So I'm curious, do you have any sort of demonstration so we can see how it works?
Yes, well, let me share my screen and I'll take you through a case that really was more of a landmark case for us. This first case was a 70-year-old male who presented with right foot gangrene, and he's been a diabetic for 30 years. He's never smoked, and he has heart disease and some high cholesterol. And this is what his foot wound looked like when he presented to us.
And it's
And
probably a good idea to just let people know that if you are squeamish at all,
yeah,
make sure that you turn away during the actual presentation. You can still listen, but you don't have to look. There are some graphic images that might upset you. But, if you have a high curiosity and you want to look, it's worth looking and following along with the case. Go ahead, Jill.
thank you for mentioning that. So this patient had all disease below the knee. And you'll see here the blacked area is where the blockage is of his arteries. But he has these nice little branches or collateral arteries feeding the foot. So what we did, you can see this is how we measure pedal acceleration time, or PAT, in the foot. We're measuring the waveform from the onset here to the peak of the waveform. And we measure this in time. And this is very abnormal because it's very slow. So you can see his arteries down in the lower leg with that collateral pathway. And so this is the first time where we really, after we did the balloon angioplasty of his artery, he has one vessel feeding his foot. This vessel is called the peroneal artery. And this is Dr. Tesso and I in a case in this 2017 photograph where we saw the change in pedal or foot flow from class 4 to class 1, which is then normal. So during the procedure, we saw this incredible change in blood flow to the foot. And that told us we didn't have to open up any other blockages. So he went on for a 4-foot amputation. Unfortunately, he did get some infection. However, over time, the PAT remained of good status, good flow to the foot. He has very nice tissue granulation. The wound is healing. And he went on to heal really nicely, despite other tests saying that he did not have enough blood flow. So this was really incredible because this particular patient who gives us authorization to share this, he was a roadster, and this was his livelihood. So if he were to undergo an amputation below the knee, it would have definitely made a huge impact in his life. So Kim, this was a great story for us early on in our discovery that made a major impact in this patient's life.
I think that's really huge. And it also helps a serious situation that we have where we have a big concern over too many procedures being done, right? And this was a case where, hey, wait a minute, stop, hold on. Let's not go back in there. Let's let the body do its thing because there is in fact blood flow. And if they didn't use this test, that patient might have had more damage done to the arteries, which may have led to an amputation, or they may not have done anything. They might have said, hey, it's sluggish, you have sluggish flow, and why delay the inevitable? Let's just cut it off now. But because of your technology, it bought the man a little bit of time to allow the body to do its natural healing process, and he's on his feet again.
Yes.
Did I describe that right? Did I summarize that?
No, that was perfect. Yes.
So, overall, what has it been like for you in terms of rolling this technology out around the world? Is there any one location that has been, more amenable to adopting it versus maybe another location where you're like, well, really? How is it that you just don't get this and you're not even giving me the time of day?
Yeah, that's a great question. New Zealand and Australia and El Salvador have been extremely instrumental in making change and implementing this into their patient care. And I think that's tremendous work on their end, especially in El Salvador. We've seen a major reduction of amputation because of this technique. And a lot of physicians are doing their own ultrasound in other countries. So I train the physicians on Zoom, and it's been quite impactful in their countries.
And Douglas has a question. We have a live studio audience here. So Douglas, what is the question you have for Jill?
Yeah, I was curious, what's the struggle you have run into getting this new technology, and why do doctors today fight that new technology when it can be so impactful like you've proven?
It's a great question, Douglas. And I would love to answer it because it's my daily struggle. Right now, in the United States, ultrasound technologists are supposed to do a set protocol with every patient, and it takes a lot of work to change that protocol and to adopt a new technique. A lot of people or healthcare providers want more data. And so I think we're working really hard to provide more data for them to be convinced that this is a test that they should be using in their daily patient care.
And here's
So
something that I always say to those doctors that say there's not enough evidence. And I say, okay, well, isn't part of medicine practicing medicine? So why aren't you, doctor, getting involved and helping to create that evidence?
Yep.
And then there's crickets. But
So
that's always my comeback to them. Why aren't you helping to create that evidence? Why are you resting on your laurels and just following, what was set in place 20 years ago when there's something new today that could help make a difference? And what harm
Right.
would it do? What harm in
Absolutely.
your situation does that do for them to adopt it?
Yeah, absolutely. This is non-invasive ultrasound. It is not invasive. It is a simple test, and I feel like I share my contact information. I'm widely available. They just have to reach out when they're if they have any questions. But I'm happy to share as much information as possible to help other patients not undergo an unnecessary amputation.
Do you find that there are any limitations in terms of the time commitment, add in pedal acceleration time or PAP to their daily regimen? And number two, any reimbursement issues when it comes to that, where they may not get reimbursed for that extra whatever time commitment it might be. And, I'm going to qualify that just a little bit and just say, because we have patients on here that are going to say, why should any of that matter if my limb is on the line?
Yeah. So there has to be a shift in how we approach CLI patients. And we have to, I think, change the way we are approaching these patients with wounds, because time is tissue. We don't have time to sit on, these wounds. And so I'm trying to teach that we need to do PAT or PAT first, and then do your ultrasound instead of starting with ABIs or TBIs, those other tests that may not be helpful in particular patients. So a lot of times ultrasound techs in the United States don't have enough time allotted to the ultrasound to do this extra bit of information. And if they practiced, it really only takes, Douglas, an extra 10 minutes. So it's a lot of information that's very impactful if they would just start with this first instead of perhaps ending with or not doing it at all. And as far as reimbursement, Kim, at the initial ultrasound, the PAT or foot ultrasound is incorporated in. But however, if you have a surgery to get more blood flow, you can bill for this study post-operatively and even intraoperatively. I go to the cath lab for these procedures, and that is billable.
Oh, wow. That's amazing. So actually during the procedure, you can give a real-time assessment of perfusion into the foot to the wound.
Yes, so I'm standing in the operating room or cath lab with my ultrasound probe on the patient's foot during an intervention. And it really tells us, is there enough blood flow to the wound bed to heal real time as we're opening up vessels?
I think that answers, especially a question that we had talked about a little bit earlier, just that, I mean, we always tell patients a less is more approach is really what should be done. No zero to hero inside these procedures. We just need that much more blood flow to get the patient on their feet and walking, just that much blood flow, right? To heal that wound. Again, no need for zero to hero. Too much is too much, and you can end up, doing more harm than good with these patients. So you being there in real time saying, oh, I think we got it. We got that blood flow. We got the perfusion to the wound. I think we're going to be good to go. No need to open up a whole bunch of other arteries because this patient should be golden.
That's right.
I love that. Hey, I'm going to be on your team. I'm going to go out and sell it.
Or that one. So not only amputations, but it sounds like this test in the beginning for just about all of us in the beginning would change the direction that most of us probably went through because it gives you a basis in the beginning, right?
Yes, and thank you for bringing that up. Can I share another case where
Yes.
if we would have gone this extra mile, we would have probably avoided a lot of difficulties. So this was a patient recently. He was presented to the emergency department with pain on the top of his foot and some speckle, colder first toe. And he has no history of smoking. And he had a palpable, meaning we could feel his pulse at the level of the ankle. And unfortunately, this patient had a normal ankle brachial index or ABI, and this patient was discharged. And this patient came back for an ultrasound. And Kim, this is and Douglas and company, this is a normal multiphasic waveform at the ankle. This looks really good. However, this is a video to show this is fresh clot in the vessel below into the foot. So the ultrasound, people didn't scan below the level of the ankle, and we see this fresh clot into his foot. And really where he had an aneurysm, so dilated blood vessel behind his knee that was throwing blood clot down into his foot.
Oh, wow.
So if we would have extended the ultrasound into the foot, we would have caught that this was more of an embolic event, and instead of letting the patient just go home. So this is a nice illustration of where we need to look further and think about the patient's clinical situation. But to your point, Douglas, if we would have just started at the foot, there's no flow to that toe based on, the ultrasound.
And I'm surprised that when you show someone this, I'm surprised that a doctor hasn't been like, oh, wow, I've had cases like this, where it seemed to have gone bad and maybe they just don't know why. And they thought they opened it up and then suddenly it turns acute. The patient's foot goes cold and they're like, well, can't do anything more because I thought I opened it up and just cut it off. Versus if they had your technology, they would know they could probably go in there with a thrombectomy device and suck it out, but also kind of fix that aneurysm.
Right. And he ultimately got his aneurysm surgically repaired, but there was such a delay of care because the patient was sent home. And You've probably seen these types of situations before, but it really, Douglas, to your point, I mean, if we would have just done the foot ultrasound at that early onset, things maybe would have changed for this patient.
So how do you see this technology evolving over the next few years?
You know, we continue to teach and collaborate and work with our colleagues around the world. Unfortunately, I've had a problem with scalability on how we can teach more people around the world, whether it be physicians, vascular ultrasound technologists, which led me to, I'm a co-founder of a company called Moonrise Medical, where we are creating AI-enabled a device for ultrasound-based hemodynamics, basically making this a device that can go on the foot and detect it automatically. So I think that it's very promising. I think that there's a role for this in podiatry, emergency departments, primary care, vascular ultrasound departments.
I mean, to make it seamless like that and just integrate it into the system and have AI do it, I think that that's going to be huge. I mean, that is the future. I mean, you would still always need another set of eyes on it, but I think that that would be a great way. And how many years out do you see this being tested? Because of course, at that point, once you get it developed, you have to go and you have to do studies and such, right?
Yeah, we have the first prototype coming out actually this month, and then we have to go through the formal process, but we're making our way. So it's actually very promising, and I think to your point, Douglas, it's going to make a massive impact on patient care at the onset of patient symptoms. And of course, there's a role for this during intervention as well.
Yeah, it's just, is there anything that patients can do to inspire their healthcare providers, their vascular specialists, their ultrasound techs to get involved and want to learn?
I think ask questions. I mean, this is really just about knowing our options. I think that if we know that we can use ultrasound to scan below the level of the ankle at the wound bed, it really can tell us a lot of information. So just sharing what you know. And Kim, I mean, I applaud you for your incredible effort and your you make an enormous impact on patients and other colleagues because of your desire to collaborate and save limbs. I mean, this is how we do it, right? We all work together and share knowledge.
So one of the questions I think that you're saying that the patients can ask their ultrasound tech is when they see them going to the ankle and they stop there, you would ask, and why aren't you taking a reading of my foot?
Mm-hmm. Yes, because at this point in time, I've spoken at enough conferences globally, and others now are speaking about it. It's pretty well known. There's a number of publications out there. So we're 7 years into this. So it's pretty well known, I think, globally.
Yeah, but there's still a lot of them, especially in the community hospitals and clinics that don't get out for much. They're overwhelmed, especially after COVID. They're short-staffed, so they can barely keep their head above water, working overtime, lots of shifts and not enough, time. And when they do their continuing medical education, so many people end up in going to seminars and classes that they already know the stuff. They sometimes just don't know what they don't know. And so they don't know to come to you. They don't know to join your seminars. And so sometimes the patients can say, hey, I need you, if you're going to be doing my legs and you're going to be with me and married to me for this journey of a lifetime, you need to know how to do the reading in the foot. Because what if I end up with a wound? And for those that have a wound, hey, I have a wound and I need to know if I'm perfusing properly in my foot, right?
Yes. Yes, and the beautiful thing about this technique of using PAT or PAT in the foot is that it's an objective number. We can measure a number that tells us if the wound will heal or not. Now, that's outside of any major infection, but it is a number that is objective.
I think that's really good to know. And I think that's something that doctors like to hear and clinicians like to hear. They like to have something that is tangible.
Mhm.
So what advice would you give to other innovators? Stay out of it, don't do it. But what advice would you give to other innovators looking to make significant impact in the field of medical diagnostics?
I think a lot of us see unmet needs or gaps in information. And when you see it, I think we're hopefully all passionate in our own way is to be curious and think outside the box. And you never know where that's going to lead you. I mean, who were to say when I scanned my own foot that it would lead me to this in this path? But it's really been an extraordinary journey.
Yeah, you can't really assume that someone else has created it. You need to, if you see a gap in care, there's still so much that needs to be done, when it comes to PAD, and especially when it comes to diagnosing PAD, advanced stages of PAD, and there's still so many unnecessary amputations that are out there preventing amputations. So a lot of opportunities, but it's not for the faint of heart. I mean, it's time consuming, right?
Yes.
And it doesn't happen quickly.
No, it does not.
7 years in and another 7 to go.
But I
What
love
keeps,
every day of it, so it's perfect.
yeah, what keeps you so committed to this every single day? Not only, treating patients every single day, diagnosing, performing the diagnostics in the Northwest and in Texas. Who knows, maybe beyond. But then also in your spare time, you have a family and then doing this. I mean, you have to have a deep, raw passion for
Mhm.
this. And I'm curious what truly drives it.
It's patient care, and it is making a difference in the lives of patients. This is what it all comes down to, is how do we impact patient care and decrease the rate of amputation. If I can, I would like to show you one last case, and this is why I do it. So this last case is and he definitely gave me authorization to share this because he is a podiatrist who called me, and I knew him from shared patients, and he said, I'm in trouble and I have been told that I need a below the knee amputation. And I said, come to me right away. And so this gentleman has been a diabetic since he was 5. He's never smoked. And he has 3 wounds on his foot, on his toe, his lateral foot, and his heel. Now, heel wounds are very difficult to evaluate with our non-invasive tests. So this is where foot ultrasound is so beautiful because I can put the probe at all 3 locations of the wound. And I also map out all of the arteries in his leg. And so here's his knee. And so you can see the black areas. This is where his blockages are in his leg. And so he had a very detailed map by me. And you can see his calcium in his x-ray of his foot. So challenging arteries. However, we know that he did not have enough blood flow to heal his wounds based on our criteria. So we took him back for an angiogram, and his arteries in his upper leg were very clean. And now we're going to focus on opening up the arteries to the wound bed. And so you can see there's the blockage here. It matches the blockage on the ultrasound. And so we were able to get through that with Dr. Constantino. She's an interventional radiologist in Portland. She's fantastic. And so we used a balloon to open up that little artery. And angiographically, Kim, this doesn't look that bad, but this is just subjective information. So we're going to use objective data using ultrasound to say that his PAT number went from bad to good, and we have got enough blood flow to not only his toe wound, but also to the lateral foot wound, just with that little balloon. And now we focus our attention on the heel. So I'm in the cath lab with the probe at the base of the heel, and we're going to open up that artery that's supplying that heel wound. And so we get through there with a balloon. We do atherectomy and balloon angioplasty, little rotor-rooter. And now this is the artery that was blocked. Now it's wide open. and we have a good PAT down to the wound bed on the table. So I'll skip through here, but you know, angiographically, it doesn't look great, but by ultrasound, it looked really good. So we follow our patients 1 hour after the surgery, and you can see where my probe is sitting. He has very good blood flow now to his heel wound and all of the other wounds. And on follow-up, we can see at 1 month, his toe wound is healed, and now his other wounds are healing. And at 2 months, 2 wounds are healed, and now we're just working on healing that heel wound. And now at 4 months and 5 months, we celebrate amputation-free survival. Like, it's really incredible. This is a patient that was otherwise
Wow.
told a below the knee amputation. And, you
Look
know,
at the color in his foot too.
yeah, it's really something to celebrate because to be condemned to an amputation where
Yeah.
the procedure worked well is really something to celebrate. So that's why I keep at it, because we make a difference and it's really wonderful.
That's amazing. I almost am afraid, but I know you probably are filled with lots of great cases. We have a series that we have started, and it's called The Pulse, and it's doctors and clinicians sharing a case in which they learned a very valuable lesson, either by a success or by a failure. So I wanted to see if you could share a case, even just verbally, with a big lesson for you and others. So describe the patient, the frustration with the case, and the lesson that you learned and others can learn for it. It could be a success, it could be a failure, it could include a little ingenuity. I mean, I could even include that case if you wanted and just use that case, but I figured you might have another one that would make your face light up as well.
Yes, I do. I think we had a case where I'm going to show it because I have it at my fingertips, because this was a patient that was told certainly no option. This was a patient who has had multiple operations, as you can see here. And if you look at the wounds on the toes, they're pretty significant and not a lot of options for intervention. So this patient would have been condemned to an above the knee amputation. And because of the ultrasound, we know he has the worst type of flow to his toes, but he also has a blockage up here in his profunda artery. And so what we ended up doing with Dr. Constantino is we did a radial access, Kim. So we entered in the artery in his wrist and did simple ballooning of that blockage. And look at the blood flow in the foot went from very bad to pretty good, all with the simple balloon. And this was just over time, he healed. And at 1 month or 1 year, he's completely healed. And he has a lot of collaterals supplying that foot. But because of that simple balloon, we were able to make a massive impact and avoid amputation. So the lesson learned here is I think we still have a lot more to learn about pedal duplex and PAT, but so far it's really proving to be a valuable test in these complex patients.
That was a great case. And here's another deep one for you. I want you to share a case that you know had you just scratching your head about how in the world this patient was not diagnosed sooner and what you wished would have happened differently with that patient. Or you could share a story of a patient who you couldn't believe that maybe other procedures were done, for example, a spinal fusion, when they should have actually been diagnosed with PAD sooner.
Yes, I have so many. But this is a very common story, is that we have very good relationships with our podiatric colleagues. So it doesn't happen anymore, but it did happen in the past where patients would have foot pain and they would blame the foot pain on their bunion. And one time a patient underwent a bunionectomy, and that ended up to be a below the knee amputation because no other diagnostic test happened before the bunionectomy. And now today, all of the podiatrists that we work with in our area, before any podiatric or foot surgery, they come to us for clearance to either a toenail removal or a bunionectomy. I mean, it's such a simple test that can really save the patient from very bad outcomes. So that was a tough story for that patient, very bad outcome.
Oh, I think that that is such an important story. I know so many people that have genetic, bunions, on their feet, and they are painful. My mom had them, my grandmother had them. I mean, led to deformities in their feet, and that is really painful. But before you do anything to that foot, especially for people, when you have 1 in 5 people over the age of 60 that have peripheral artery disease, and it gets even more likely as you age, you got to get that blood flow checked and make sure that if you do have a major procedure. And we did have a patient that ended up just posted in our network just the other day. And you know Dr. David Alper really well. And he jumped in because her podiatrist said, hey, you know what? I don't want to touch this ingrown toenail until you go to vascular first. I know time is tissue, but you got to go. I don't want to touch that until you get vascular. And Dr. Alper's like, yeah, but make sure sooner rather than later that you do get that checked, because those are painful and those can turn very, very quickly.
Yes, yes.
So I have one more question for you. And our producer, Josh, just wrote in our chat, I think I'm getting to know why you won this award. And I agree. Jill is amazing. And I feel so blessed to have been to different conferences and have traveled, with you around the world to see you in action and to see you educating so many physicians and clinicians and even patients, along the way. So I'm really curious with you, because you are so deep and you have, real reasons deep down why you do what you do. So we do have another series, and it's going to be the 6 minutes that matter. And I'm curious, what are the 6 minutes that truly mattered in your career? That was it a conversation you had, a movie you watched, something you saw that was eye-opening, a conference you went to, a specific talk that was the spark or the catalyst that led you in a certain direction or to do something? But it's one moment in time, 6 minutes that matter.
And those 6 minutes is the recognition from vascular surgeons that I mattered. Because I'm a vascular technologist and not a physician, they actually believed in my contribution and brought me in. Though that's when it matters, is that I contribute just as much as they do. So there was, does that make sense? They believed in me and that I was part of the team, not just off to the side, that ultrasound and my thoughts and my discovery really were going to make a difference.
So the 6 minutes that mattered for you is, those 6 minutes where you were sitting there and they actually saw the difference in what your technology provided.
That's correct. Instead of just looking at, yes.
Because they could actually see during even the procedure itself, they have opened up the posterior tibial artery and they just ballooned it, and they could see in real time with your ultrasound strategically placed just, at the heel, they could see that real-time perfusion to the wound bed.
And those 6 minutes happen again and again and again, whether I'm with Dr. Constantino, Dr. Tesso, Dr. Montero Baker, Dr. Patron, Dr. Isa. I mean, they happen again and again, and I'm lucky enough to be able to scrub in with these physicians, but I hope they continue, Kim.
Yeah, and it's with and again, for those just joining now, that have come in a little later, joined into our live, it's what's called pedal acceleration time. And it's just an advancement in diagnostics for PAD that was created by technologist Jill Somerset out of the Northwest. If you're lucky enough to be in the Portland area, or you still go to Houston with Dr. Miguel Montero Baker, which I can see.
Douglas, are you there?
He's there. And if you stay on afterwards, I'm going to have you sit with me for a couple minutes and just explain to him why it's worth the drive to go see Dr. Miguel Montero Baker as well. So Jill, again, I just want to wish you a very warm congratulations and a huge thank you for all you are doing to fight for the limbs of our patients. And, you know, by this interview, if we can empower every single patient that watches this interview to simply ask their technician, someone that's doing the ultrasound, hey, why aren't you checking my feet? Check my feet. Take that wand and check my feet. Learn the pedal acceleration time, because it could make the difference in not only my limb, but my life.
Well, thank
Our
you.
diagnostics pioneer of the year, Jill Somerset, thank you so much.
Thank you very much. I am so grateful.